Hello, everyone. Welcome back. Hope you're all well. Navid here from Edinburgh Endodontist. Today, we are continuing with our short clips on traumatic dental injuries. We've already covered infractions, enamel fractures, and enamel-dentine fractures, which are also referred to as uncomplicated crown fractures, as they don't involve the pulp, as you recall. Today is enamel-dentine-pulp fractures turn. As the name suggests, the pulp is involved now, so these injuries are also known as complicated crown fractures, as opposed to uncomplicated. The aims and learning outcomes were discussed on day 1, which you can find under infractions clip. Please watch that. We also stressed the importance of time in the management of traumatic dental injuries and went through the etiology and the risk factors. Please watch the previous clips to recap if needed, especially the infractions, because we went through all these risk factors then. This week, we go through fracture injuries and next week, luxations. And today, pulp fractures. As I've already explained, and the name suggests, these injuries involve the loss of enamel, dentin, with visible pulp exposure, and also referred to as complicated crown fracture. Clinical findings include sensitivity to both temperature and touch, but should not be tender to palpation. You may ask what the difference is between touch and palpation because they are kind of the same. Well, they are. However, by touch, tenderness to tactile or percussion, we mean the tooth. And by palpation, we mean soft tissues. So if you have a fractured tooth only with no luxation injury or swelling, for example, an abscess tooth, you should not have tenderness to palpation on the soft tissues. But if you have tenderness to palpation, look for luxation. All right. So tactile and tenderness to touch, they mean teeth. Palpation means soft tissues. Radiographic examination will reveal enamel and dentin loss, pulp chamber breach, depends how severe it is. You may or may not be able to see it, but look for it, and also how large the pulp chamber is. But normal root and periapex. Try to get into a habit of a full systematic clinical examination of all teeth and soft tissues, and take multi-angle radiographs of the region just to make sure you're not missing anything. As we've already briefly discussed, labial tenderness could suggest a luxation injury and should be investigated further. Take multiple periapicals, check socket outline and PDL to see if there's any enlargement, indicating a luxation injury or displacement. But don't worry, we will discuss these next week in full. Also, you may recall the advice regarding the lost tooth fragments. If you can't find them and have, for example, lip laceration, take a soft tissue, i.e. lip radiograph to see if it is dislodged and it is in the patient's lip, the broken fragment. We discussed this in the second clip that you can find under enamel fracture. So if you look at previous clips, the way to take the radiograph is discussed. 30 to 50% exposure and and how to take the radiograph. So please watch that clip. The management in primary teeth involve a Schweck pulpotomy to preserve the vitality. However, if pulpotomy is not possible for whatever reason, consider the full removal of the pulp or extraction. In permanent teeth, if you have an exposed or near exposed pulp in adults, you should do a pulpotomy to remove the inflamed superficial pulp. Now, this is a bit tricky, as you may ask, how do I know which bit is inflamed? As a general rule of thumb, if the pulp bleeds, but coagulates within a few seconds by applying pressure, like a cotton, pellet or something, it is healthy. So if it bleeds when you touch it and then it stops bleeding after applying pressure for a few seconds, then that's healthy. It should look nice and pink. If you use microscope, you can see nice blood vessels inside. So that is healthy. Obviously, it's not a microscopic sort of laboratory analysis of it, but clinically that is healthy. If, however, it doesn't stop bleeding, it is unhealthy and inflamed and needs to be removed. Remember, trauma and fractures, if immediately presented to you and quickly managed, the pulp should be okay, as it hasn't been exposed for too long to the environment and has not had time to get seriously inflamed. Okay, so bacteria have not had enough time. Remember, pulp and pulp chamber, it is a positive pressure towards the outside, so it tries to help itself. So even if it gets exposed, it tries to sort itself out. However, it's a big difference between this sort of injury to the pulp and a continuous chronic long-term exposure, for example, by micro leakage from recurrent caries. So these are completely different sort of insults to the pulp. So in trauma, it is a clean inflammation, generally speaking. So the success should be high in terms of preserving the vitality. This is especially important in immature teeth, those with open apices and thin root walls. And the aim here is to preserve the vitality in these teeth to help root development, because this is a favorable treatment, and if it is carried out quickly and efficiently, it will result in a high success rate and tooth retention and pulp vitality. Remember, time is crucial when it comes to success. Immature teeth, if lose vitality, will have a poor long-term prognosis and are a higher risk of future fractures, especially cervical and root fractures in years to come. If you preserve the vitality, however, you will help root development and improve the success and survival. Now, if you want to watch the video of pulpotomy, you should go to the members area of Dental Trauma UK. So make sure that you go and visit and become a member to be able to watch all these clips, not just pulpotomy, but other clips as well. But I'll show you some close-up photographs of a pulpotomy case here. So first of all, try to see if you can reattach the fragment, if it's been identified. Try to see if you can reattach it. This should be your first goal. Relocate and check, make sure you don't drop it on the floor or worse, at the back of the patient's throat. I usually place a few gauze squares behind the tooth, just in case I drop it. If you've already placed a rubber dam, then that will take care of the safety aspect of it. Then do pulpotomy after isolation. You see here that there's no rubber dam. So the operators use the PTFE tape to facilitate bonding and reattachment. They've used cotton rolls and gauze. And it depends on what you are used to, what you have. Remember, time is very important. You've got a traumatized, generally speaking, child or teenager might be very upset. So if you want to faff about putting a rubber dam on for half an hour, then it's not going to work. You lose patient cooperation. It goes south. So do whatever you're comfortable, because speed is very important here. But also efficiency in what you're doing. So if you are not used to rubber dam, then just isolate using gauze and cotton rolls, as you can see here. I personally use rubber dam, split dam technique to easily place and remove the dam, and it is usually simple for me because I do it on a daily basis. Now, the superficial pulp can be removed with a high speed burr, diamond burr. I would say 1 or 2 millimeters maximum. As we've already discussed, these are clean fractures, so it should be all right. Especially the smaller the exposure, the better the prognosis. And then use a very small moist cotton or foam bud pellet to apply pressure for a few seconds. Make sure it's moist. And then remove it and observe. If there is bleeding, remove another 1 or 2 millimeters. But remember, the trauma, if it has just happened, you're seeing the patient, almost immediately, the pulp should be okay. So you only need a millimeter or so here, for example, as the exposure is small. But anyway, if you see bleeding after a few seconds of compression, remove another 1 or 2 millimeters until you get to healthy, coagulating, non-bleeding pulp. Then cover the healthy pulp with either calcium hydroxide or bioceramics and seal with a glass ornament. Please do not use MTA, as it will stain and discolor the tooth. Also make sure that the glass ionomer that you're using is just placed carefully in the pulpotomy access cavity and not over the dentin, because you need to be able to bond the fragment back without any issues. So make sure that it only goes into your access cavity for pulpotomy, the glass ionomer. Then etch and bond the tooth and the fragment. There are these sort of restoration holders, the stick ones that you can use to stick the the handle to the fragment. But again, whatever makes your life easier and you're familiar with, to be able to complete the procedure efficiently and quickly. Do not over dry the tooth, so make sure you do that. Use micro brushes and paint the flowable composite on the fragment and tooth. Put the fragment on the tooth, reposition just to make sure that you've got it right, and hold it with a firm pressure, and then do a short cure. Then remove the excess composite. After that, fully cure both labial and plateal and polish gently. As the tooth and the broken fragment been dehydrated, it will look whiter and opaque. So that's not a problem. Just advise the patient that it is fine, reassure them. And tell them that after rehydration, it will recover. Now, if you get an aged tooth, a tooth with a closed apex and mature root balls, if you have to remove the pulp up to the cervical aspect to get to healthy, uninflamed pulp, perhaps it is then time for excavation, because then we may be asking too much of a tooth. It really depends on the age of the pulp. But this is not the case with immature teeth. Remember, obviously, it is difficult if you do one procedure like this a year, but always stick with the basics. do it systematically, use a step-by-step approach, just read up on it as you go along. If you got in a background on the, Dental Trauma UK website, keep checking, it's not a problem. In mature teeth with open apices, try to preserve the pulp, the main lesson, take home point. But in mature closed apex teeth, if you're going too deep to sort of cervical aspect and it's still bleeding, then maybe it's time for you to do the full root canal treatment. But with immature teeth, preservation of vitality is essential. We can even try these days, different regeneration procedures. So go up to cervical in immature teeth, open apices, and immature root balls. If still bleeds, dress and refer, okay, so that you can get the best outcome by a specialist. But say the mature teeth at CEJ, go for root canal treatment. Monitoring wise, should be done in 3, 6, and 12 months, and then annually, just like the uncomplicated crown fractures, with clinical sensibility and radiographic assessment. So, to sum up and recap, so far we've talked about infractions in which you reassure the patient and parents and review annually. In enamel fractures, smooth down small chips or reattach fragments if you've got any, or build up with composite and review annually. In enamel dentine fractures, similar to enamel fractures, smooth, small, chips, reattach or build up depending on what you've been presented with, really, and if you've got the fragment. And review in 3, 6, and 12 months, and then annually. And finally, in Enamel-Dentine-Pulp fractures, do a pulpotomy using calcium hydroxide or bioceramics, but not MTA, remember, and seal with glass ionomer and restore the tooth. And review in 3, 6, and 12 months, and annually thereafter, looking for evidence of pain, discomfort, sensibility testing. Shouldn't have any swelling, you shouldn't have any discharge, no mobility, no sign of apical radiolucency, no sign of resorption, vitality is still there, and so on and so forth. Okay, I hope that you found this short clip helpful. Check Dental Trauma website for the video clips of the procedures, please. And come back tomorrow for another short clip on, this time we're getting even more serious root fractures for tomorrow. It's getting exciting now as we start thinking and talking about splinting. So stay safe, take care, and goodbye for now.